and our researchers at the Rady Genomics Institute to really transform how we are taking care of very critically ill babies in the NICU and PICU at Rady Children's. So let me give you a little bit of context. Rady Children's is both the provider of choice as well as the safety net providers for pediatric care in San Diego. And this is relevant for precision medicine because precision medicine is a numbers game, right? And you need a lot of data. And we just so happen to have taken care of virtually every kid in the San Diego region. And what that means is that we see kids with very diverse genetic backgrounds, right? All ethnicities, very diverse segments of the population on the socioeconomic strata, right? And very different environments. And that gives us a very rich bank of data from which to pull from. In addition to that, it so happens that all this data resides on a single instance of our EHR that comprises information from both primary care, specialty care, acute care, post-acute care. So very rich data, easy to get to. Last but not least, we're in San Diego. Southern California is the Silicon Valley equivalent of genomics, right? So we have tremendous access to brilliant minds in both academia and private industry with whom we can partner. And so that sets the stage for what started in 2014 for us, which this tremendous gift from the Rady family, where Ernest and Evelyn Rady gave us $120 million to start a genomics institute focused on pediatrics. And when you have good funding, things become just a little bit easier, right? So, in 2014, the Rady family made this gift to us. In 2015, we brought in Stephen Kingsmore to run the Genomics Institute. Stephen came to us with a grant from the NIH focused on rapid sequencing in the NICU. And that's where we started our genomics efforts. From him, we learned that somewhere between 20 and 30% of the kids in the NICU and PICU actually have a genetic disease that causes or impacts their condition. We also learned that genetic defects are the leading cause of mortality in the NICU. And even though there are over 8,000 known genetic defects, many of which are treatable if we can get to them early on, the reality is that today's newborn screenings don't allow us to identify many of these. So let me give you an example. Let's say we run into a baby who has a genetic defect in a gene involved in how they can process some nutrient. Let's say that nutrient happens to be the calcium in the mother's milk. Every time that baby is fed, he's getting poisoned. Right? If we don't know what's wrong with them, we can't change that course of treatment. Right? And in some cases, we're not going to find out that the reason why they're not doing well is because they have this defect that prevents them from processing that calcium in their mother's milk. But if we can get to that early on, right, change a diet, a supplement that allows them to process that calcium, gets them up and running again. Right? The longer they go without a diagnosis, the longer their organs keep getting damaged by that nutrient that to them is a poison. Yeah. So obviously, speed is of the essence. There are about 3% of children born in the US every year that are impacted by a genomic defect. We believe that that means somewhere between 70 and 80,000 babies that are born in the US every year could benefit from the work that we're doing at Rady Children's. Maverick is one of those babies. I'm going to let Dr. Kingsmore tell his story.
Yeah.
Yeah, you like Dr. Kingsmore.
I can't see. I have to take my glasses off. Yeah.
We were scared. We didn't know what was happening. He was in pain and he wasn't able to eat. He was, at one point throwing up blood, and that was really, really scary. We didn't know what was happening, and I was trying to stay hopeful, but it's hard when you see that to be hopeful. But, with Rady Children's, we figured that they were the best hospital for our son to be at.
Seizures are very common in young babies, and there are hundreds, there's over 850 different causes of seizures. Some things are really common, like infections, or if a baby has a fever. But in Maverick's case, these seizures just kept coming and weren't responding to normal treatments. And so it was clear that there was something very serious going on. And by decoding his genome, we were able to look at all 850 conditions that can trigger a seizure and find out exactly the one which caused it in Maverick, which resulted in completely different treatment. And what's amazing is, as you just heard, Maverick was dying. And instead of that, within 36 hours, he was off all seizure medicines, and he had the breathing tube removed. Yeah, and he was able to feed. And that was a big deal, right? That was a really big deal. And his outlook was great.
Mm-hmm.
And tragically, all around the United States, other mums, dads, other babies aren't yet receiving this. And it can take weeks or months or even years to figure out what's the specific trigger. So Maverick is missing a single protein that makes a single type of enzyme, and we can prevent him having any symptoms by just giving him B6 and changing his diet a bit. Yeah. But you'd never know that. That's not on the standard set of things that you would routinely go through in a baby who's having a seizure. So he's a miracle that we found this in time before he had, irreversible damage. And the great thing about babies is their brain is still growing, and so he came through this, and he's doing great. Yeah, you're doing great.
So pretty amazing, right? So the great thing is that if we target the right patient population, making this kind of testing available to them can make a tremendous difference in their quality of life, the care that they receive. And it's great not just from a care standpoint, but it's also great because this has economic utility, right? By even being able to quickly identify a diagnosis, by being able to quickly get to the adequate treatment, we can get those babies out of a very high intensity, high cost setting onto a lower care and lower cost setting, and therefore make an impact not just on their health, but also on the financial impact that their illness has on their families. So let me continue with our chronology. In 2016, our genomics lab got CLIA certified. And so we went from doing research to actually taking care of kids in real time. And the word got out. And suddenly there was tremendous interest from other children's hospitals, but not every other children's hospital is as lucky as we are to have a Rady family behind them who is able to fund the tremendous investment that is required in both people and technology to make this happen. So as we often do, Rady Children's partnered with a number of other providers across the nation. I believe we are now working with 26 other children's hospitals. There are a few more in the pipeline where we've become the reference lab for rapid whole genome sequencing. So you might be curious about how the process works. So once the patient is decided that they're a good candidate for a genomic sequencing, they get consented, and then samples extracted and prepped, and all gets ready to do the actual sequencing. And that is incredibly intensive from a computational standpoint, but that part of the analysis is relatively automated. Simultaneously, the physicians go into the patient's EMR and pour through it and extract what we call a deep phenotype. And then that data provides the context when brought together with the output of the genomic sequencing to compare it against a number of reference databases for known genetic defects to come up with an actual diagnosis. And once that diagnosis is made, then our clinicians, our scientists work together to first interpret the result and define the right course of action for the patient. Well, this is an incredibly high-tech process on the right side, but incredibly low-tech, if you will, on the phenotype side, very high touch, if you will, which means it's not really scalable. So sometime in 2018, we were at a meeting with Stephen Kingsmore and several members of his team, and myself and Josh and some other members of the IT team at Rady Children's, and we also had a couple of our vendor partners there. And Stephen Kingsmore completely went off script, and he goes, this is not scalable. Why don't we automate the whole thing? And sure enough, there was maybe a fraction of a second of pause, of silence in the room, and you could start to feel the excitement and heads shaking yes. And lo and behold, we went ahead and did it. Challenge accepted, right? So we started with rethinking forms, our smart forms in the NICU, making sure that we were capturing more discrete information. But then we also brought in natural language processing to really pour through those notes that have this rich qualitative descriptions on them that allow us to actually get really, really deep into the phenotype of the patient. But we then run into another challenge, which is our clinicians happen to think and speak ICD-10, LOINC, right? But our scientists happen to think and speak something called HPO, which stands for Human Phenotype Ontology. So we needed to make those two different languages talk to one another. And then we needed to automate all this process that allowed us to extract the data and combine it with the genetic data and push it against all of these reference databases to actually be able to come up with a diagnosis. So this is how the process looks now. The biology side of it stays the same, but the phenotype gets automated. The moment the physician places an order, right, that generates a process where the phenotype is extracted from the EHR, sent to a holding warehouse, and then once the genomic results are available and combined, the magic happens, and we get to a diagnosis that then gets pushed back to the EHR. Right? That has allowed us to bring this process that in the industry takes an average of 6 weeks. When it was manual, we were on average doing in 5 to 6 days to less than 20 hours. Now, we don't do this in less than 20 hours routinely. Everything has to kind of be lined up perfectly for us to get to that number. But we can routinely do it now in 2-3 days, maybe tops. There's a good article that was published last spring in Science, Translational Medicine. If you're interested in the crux of how it all works, it works through our process. Now, the outcomes are impressive when you think that 10% of the kids in the NICU and PICU drive about 70% of the costs. In the acute care setting, we've done now over 1,000 genomes. We are working with payers. We're working with the state of California, with Medi-Cal. We're working with United, a couple other payers, to really prove the utility of these small cases, smaller cohort cases that we've studied to make sure that they pan out for the totality of our cases. But the outcomes have been impressive, not just because we can do this quickly, as I just described, but because we can do it accurately. Right? We are able to get to an actual diagnosis in 1 out of 3 cases that we see. More importantly, that diagnosis drives a change in the management of the patient in 1 out of every 4 cases. And that change in the care that we provide to that patient leads to improved outcomes in 1 out of every 5 cases. So that's impressive. Now, doing this takes laser focus vision. Right? We did not try to boil the ocean. Right? We focused on one use case that made sense, where we thought we could have the biggest impact, and we went there. I'm quickly going to go through our recipe for success. First, we went at it checking our egos at the door. This was not about me or IT. This was not about Stephen Kingsmore or the scientists. This was not about any of our neonatologists in the NICU. This was about those patients and those families. We made sure that we had a shared vision. We all came at this from different angles. Right? The scientists had their view of the world. The clinicians had their view of the world. The technologists had our view of the world. But ultimately, we made sure that we had a shared vision, and that vision had clear line of sight, not just at the executive level, but through every single member of our teams. And I can tell you that when I walk into our data services team or our informatics team, they are so excited about the work that we do here and how they see their contribution to really changing the lives of children. So vision, critical. Keeping an open mind. I think we've gone full circle twice, if not 3 times, on how we set this all up. Both from an organizational structure, from a process standpoint, from a technology architecture. Right? We're gonna, inventing the plane as it flies, or call it, pick your analogy. This was one of those things where a rigid mindset had no place. Right? Speed trumps process. We had to go at this as if we were a startup. Right? We have a tendency in clinical care to want to make sure that we measure twice, we cut once, everything is perfect, right? We don't want to cause any harm. But in this case, speed was of the essence. So design quick, build quick, fail quick, learn something from it, start all over again, rapid cycle. Right? We really had to embrace that startup mindset. And at the same time, don't be fooled, because the moment we went from research to clinical care, then that availability becomes critical, redundancy, repeatable process, right? So I know it sounds like I'm talking out of both sides of my mouth, but the reality is that was the world we were living in, right? We had to deal with these tension of moving fast, and yet at some point make sure that we were being safe. Partnership is essential, right? No one single group of people could accomplish this on our own. Right? We needed all components to really be rowing in the same direction. Right? So what I tell my team is be the glue. Right? Don't worry about being the hero, but make sure you are the glue. And then last but not least, right, don't let perfection get in the way of progress. Right? This was all about small, continuous, incremental changes. And what we found out is that these kind of ongoing mini evolution ended up revolutionizing how we are providing care in the NICU. So that has been our recipe, and my challenge to you all is, what's your recipe for innovation? Thank you.